Welcome to the Funnel Effect. Today, we are undertaking a really critical deep dive into arrhythmogenic right ventricular cardiomyopathy, ARVC. This is a complex, inherited heart condition, and honestly, it's one of the most challenging diagnoses in cardiology, mostly because of its potential for sudden cardiac death, often striking young adults or athletes seemingly out of the blue. We're basing our discussion today on a really comprehensive state-of-the-art review. It's titled Arrhythmogenic Right Ventricular Cardiomyopathy, and it does a great job synthesizing the modern, kind of evolving understanding of the disease. The authors on this important paper are Andrew D. Cran, Arthur A.M. Wild, Hugh Calkins, Andre Lagersh, Julia Cadron-Tournier, Jason D. Roberts, and Hui-Chin Han. Quite a team. So our mission today really is to give you a shortcut to understanding the three essential pillars of ARVC. First, the molecular catastrophe, what actually causes it. Second, the rigorous task force criteria used to diagnose it. And third, the modern strategies used to manage the risk.
It's absolutely right. When we talk about ARVC, we're essentially defining a disease where the heart tissue, specifically in the right ventricle, or RV, gets progressively replaced by fibrous tissue and fatty tissue. We call this process fibrofatty infiltration. And this structural damage creates, a chaotic electrical substrate inside the heart, leading predominantly to really serious, often life-threatening arrhythmias. What's crucial for you, the listener, to grasp right away is just how much our understanding of this disease has shifted since it was first described back in the late 1970s, early 1980s. Initially, it was seen as purely an RV-dominant condition, hence the name, right? Arrhythmogenic right ventricular cardiomyopathy. But now, clinical practice shows us that involvement of the left ventricle is actually frequent. It's significant. This has led many experts to suggest a broader, more inclusive term, arrhythmogenic cardiomyopathy, because it's often biventricular disease we're looking at.
Right. Given its severity, especially that risk of sudden cardiac death, I think a lot of people might assume it's incredibly rare. But the numbers suggest it's more like uncommon, not exactly rare.
Exactly. It's an inherited condition, and it impacts a significant portion of the population. Prevalence estimates do vary quite a bit depending on the group studied, somewhere between 1 in 2,000 to maybe 1 in 5,000 people. Even if we take the most conservative estimate, that still means millions of people globally could be carrying this risk. We also see a slight male predominance. Around 55% to 60% of diagnosed cases are in males. For those individuals, getting an accurate diagnosis and really precise risk management isn't just important, it's potentially life-saving.
Okay, so let's dive right into the cellular level then, because I think if we don't understand the structure that fails, the rest of the diagnosis and management just won't click,
Okay, so we start with the absolute foundation of how every heart muscle cell, every cardiomyocyte functions. The intercalated disc. Now, this isn't just some simple boundary between two cells. It's a highly complex, integrated piece of machinery. Think of it as this really specialized interface that makes sure adjacent heart muscle cells communicate electrically and stay mechanically linked, through the massive forces of every single heartbeat. It's sometimes called the connexome.
I like that term, connexome. It really captures that interwoven complexity right away. Can you break down this machine for us? What are its essential parts and what do they do?
Absolutely. So the intercalated disc is made up of 4 main integrated functional domains. They all work together. First, you've got the adherens junction. This part is mostly responsible for structural alignment and stability. Its key component is a transmembrane protein called N-cadherin, or NCAD for short. NCAD connects the cells on the outside, but internally it links directly into the cell's internal framework. That's the thin or actin filament cytoskeleton. It does this via crucial proteins like beta-catenin and alpha-catenin. So its main job here is keeping things aligned and transmitting force.
Okay, so the adherens junction keeps the cells lined up and talks to the contraction machinery. But what gives it the sheer strength needed to handle, decades of constant mechanical stress?
That's the job of the second component, the desmosome. This is like the heart cell's superglue. It imparts really robust mechanical strength. The key players here are other cadherin glycoproteins, desmocolin, DSC, and desmoglein, DSG. Specifically in cardiomyocytes, we're looking at isoforms, DSC2 and DSG2. These proteins anchor the cells together on the outside. Intracellularly, they connect to a different part of the cytoskeleton, the intermediate filament system, made of desmin through a large protein called desmoplakin, or DSP.
So if adherens junctions are the scaffolding and desmosomes are the superglue, they're working together to resist these huge mechanical shear forces from the pumping heart. That makes sense.
Precisely. And there's a key protein that helps make sure these two systems, the adherens junction and the desmosome, actually function as one unit. That's glycophilin 2, PKP2. PKP2 is actually one of those commonly mutated proteins in ARVC. It acts like a scaffold, helping the interactions between the desmosome complex and the actin cytoskeleton of the adherens junction. It links them. Okay, now for the electrical side of things. The third component is the gap junction. This is the specialized portal for electrical communication and also some metabolic coupling. It's mainly composed of a protein called connexin 43, CY43, in the ventricles. These proteins form channels that let ions and small molecules zip rapidly from one cell to the next. This is absolutely essential for coordinating the action potential, making the entire heart muscle contract synchronously.
Right, the electrical wave. And the fourth component.
That's the collection of surrounding ion channels. These include the really key voltage-gated sodium channel, Navy 1.5, various potassium channels, and the pump, the TexNav plus TexDecay. Critically, these ion channels aren't just floating around freely. They're actually tethered to this whole intercalated disc complex. They often interact directly with desmosomal linker proteins like PKP2. So when the desmosome fails mechanically, the electrical conductivity often fails too. The mechanical failure and the electrical failure are, well, they're inextricably linked by these scaffolding proteins.
Okay, that gives us a solid foundation. Now let's talk about the specific genes, the ones whose failure causes this whole structure to basically collapse. The search for the root cause of ARVC has really focused overwhelmingly on genetics, hasn't it? We know that a causal genetic variant is found in about 2/3 of patients who actually meet the diagnostic task force criteria, which makes genetic screening pretty indispensable, both for the patient and, crucially, for their family members.
Yes, absolutely. And the majority of these genetic culprits, we're talking 50% to 60% of all diagnosed cases, are found within the desmosomal genes themselves, those genes that code for the proteins of the desmosome and its associated structures. The most common culprit, by a pretty significant margin, is PKP2, the gene coding for plecophilin 2. Just this one gene accounts for anywhere between 20% and up to 36% of all clinical ARVC cases. It's a huge player. Then we see variants in DSP, which codes for desmoplecin, DSG2, desmoglein2, DSC2, desmocolin2, and much more rarely JUP, which codes for plecoglobin.
That source material highlighted a really striking variability in PKP2 prevalence. You said up to 46% in US and Dutch cohorts, but then only 14% in some Italian cohorts. What's driving that huge geographic difference?
Yeah, that's a great question. It's likely a combination of factors. First, it probably speaks to things like genetic drift and founder effects, so specific mutations that became concentrated in certain geographic areas or population groups over generations. Second, it could reflect differences in how patient groups or cohorts are defined. Are they defined just by clinical criteria or by a mix of clinical data and widespread genetic testing? That can skew the numbers. This variability really underscores that ARVC isn't just one single disease. It's more like a spectrum of phenotypes, all caused by failures in this shared cellular hub, the intercalated disc.
It's interesting, though, that while most cases are desmosomal, you mentioned there are these non-desmosomal genes that still somehow manage to produce the classic ARVC phenotype.
Yes, and that's a really key insight. These non-desmosomal genes include TMM43, DES, which codes for desmin, part of the intermediate filament, and PLN, phospholamban, involved in calcium handling. Even though they don't directly code for the desmosomal components themselves, variants in these genes have been shown to kind of secondarily mess up the function or reduce the amount of desmosomal proteins. So they still end up compromising the integrity of the intercalated disc. The end result is basically the same: mechanical weakness and electrical problems.
You mentioned JUP being rare, but it is linked to those famous syndromic subtypes, right? The ones that really illustrate how systemic these proteins can be.
Indeed. These are the rare autosomal recessive cases. So Naxos disease is caused by a JUP variant, and it presents with the classic ARVC heart symptoms, alongside very distinct skin and hair, features like woolly hair and thickened skin on the palms and soles, called palmoplantar keratoderma. Similarly, Carvajal syndrome, which is caused by homozygous DSP variants, meaning two faulty copies, presents with similar skin issues. It really drives home the point that the desmosome is critical for strong cell-to-cell adhesion, not just in the constantly beating heart, but also in tissues under mechanical stress like the skin. That's why we see these multi-system effects.
And finally, just touching on genetic risk again, we should probably reiterate the gene dosage effect.
Oh, absolutely critical for thinking about prognosis. Individuals who are compound heterozygotes, meaning they carry problematic variants in two different ARVC-associated genes,
Yes.
or those who are homozygous, carrying two faulty copies of the same variant, they tend to develop significantly more severe, and often much earlier, clinical disease. Basically, the higher the genetic burden, the faster and more aggressively the disease seems to progress. Okay, let's shift now to the pathophysiological consequences, because this is where modern science has really overturned some historical assumptions. We now know the problem starts well before the heart wall visibly turns to fat and scar.
Right. Historically, the defining feature was always that structural replacement, the loss of RV muscle cells, replaced by fibrous and fatty tissue, often described in that classic triangle of dysplasia.
Yeah, that triangle affecting the RV inflow tract, outflow tract, and apex, that's really a description of advanced ARVC. But the true arrhythmogenic substrate, the source of the dangerous rhythms, is far more complicated and patchy. It involves failure across the board, gap junction dysfunction, reduced sodium current flowing through those channels, and profound dysregulation of how the cell handles intracellular calcium. So what actually drives the structural replacement itself? This ties back to the adherence junction components we talked about. The structural changes seem to stem from the downregulation of a key signaling pathway called the canonical want pathway. Remember beta-catenin linked to NCAD in the adherence junction. Well, it's also a critical player in this want pathway, which is essential for promoting myogenesis, that's muscle development and maintenance.
Okay, so if the want pathway gets blocked or dampened, the cell essentially gets confused about what it's supposed to be doing.
Precisely. The mutation, often a variant glycoglobin, PKG, which should be in the desmosome, seems to interfere and compete with the normal beta-catenin signaling in the nucleus. When this want pathway signaling is reduced, two disastrous things tend to happen at once. First, it promotes adipogenesis, which is the cellular program telling the cell to turn into fat tissue. And second, it seems to activate another pathway called the hippo pathway. The hippo pathway promotes cell apoptosis, basically, programs cell death. So, the heart muscle cells are essentially receiving signals telling them to die off and be replaced by fat and fibrous tissue. It's like a programmed self-destruction sequence gets initiated.
Wow, that's a fundamental failure of cellular programming. You mentioned the most significant insight, the one that's really changed how we manage high-risk patients, is that the electrical instability seems to precede the visible structural destruction.
This is the critical paradigm shift, yes. We used to think the arrhythmias were simply a result of the physical scar tissue disrupting the normal electrical conduction pathways, like electricity having to navigate around roadblocks. Now we understand that the arrhythmogenicity, the tendency to have dangerous rhythms, is an inherent functional problem that exists long before gross structural change is obvious on an MRI scan, for instance. This is where the calcium handling comes in, especially in ARVC associated with PKP2 mutations. During high adrenergic stress, think intense exercise, the heart needs extremely precise control over intracellular calcium to contract powerfully and rapidly and then relax just as quickly. Research, particularly using mouse models where PKP2 is knocked out, shows that the failure of PKP2 disrupts the cellular machinery responsible for managing and recycling calcium. This leads to increased calcium leaking out into the cytoplasm when it shouldn't, and also overloading the internal calcium store, the sarcoplasmic reticulum.
And what does that extra calcium leak do electrically? What's the consequence?
That spontaneous calcium release from the overloaded stores causes electrical disturbances called delayed after depolarizations, or DADs. These DADs are like tiny electrical sparks that can trigger the premature ventricular complexes, or PVCs, that we see on Holter monitors. And if enough of them happen, or under the right conditions, they can initiate lethal ventricular arrhythmias like VT or VF. Since this whole calcium leak process is highly dependent on sympathetic tone, that adrenaline surge you get during physical exertion, this maladaptive calcium response provides the direct molecular explanation for that core clinical link we always observe. Exercise is the dangerous trigger. It explains why ARVC events tragically often happen during or immediately following intense physical activity. It directly stresses this faulty calcium handling system.
Okay, so we have a clear, multi-layered pathology here. It starts right down at the desmosome, leads to this early electrical chaos fueled by calcium problems, and gets accelerated by exercise, eventually leading to structural replacement. Now we need to bridge that deep scientific understanding to the clinic, to the bedside. How do we actually bring all these different pieces of evidence together to make a confident, definitive diagnosis?
That is precisely the role of the 2010 Revised Task Force Criteria, or TFC. Because ARVC is progressive and it presents so variably between patients, the diagnosis absolutely demands a systematic multimodality approach. This isn't a disease where, one blood test or one scan gives you the answer. It really requires integrating information from the clinical history, the ECG, advanced cardiac imaging, and sometimes genetics, and even pathology from biopsies.
Can you quickly remind us of the sort of tiered structure of the diagnosis, how they classify it? Certainly. A diagnosis is considered definite ARVC if the patient meets either two major criteria or our one major criterion plus two minor criteria or our four minor criteria. Critically, those criteria have to come from different categories or domains of evidence, like one from ECG, one from imaging, etc. There are also intermediate stages, which are important. You can have borderline ARVC, for example, one major plus one minor or three minor criteria, or possible ARVC, one major or two minor criteria. This structure is really helpful because it allows clinicians to identify and monitor patients even when the disease might be in its more subtle early stages.
Let's focus first on those crucial electrophysiological parameters. What should clinicians be looking for in a standard 12-lead ECG? That's often the first test, right? The ECG is absolutely foundational. The primary marker of a repolarization abnormality, and this counts as a major criterion, is T-wave inversion, TWI, in the right precordial leads, specifically V1 through V3, or sometimes even beyond V3, in patients who are over 14 years old and don't have a complete right bundle branch block, CRBABB, because that can cause TWI on its own. The extent also matters. TWI that goes all the way from V1 to V4 is seen in the majority of classic ARVC patients.
Okay. And what about the epsilon wave? That's the famous one, although I hear it can be kind of elusive sometimes.
Ah, yes, the epsilon wave. It's a very specific low-amplitude signal that appears right at the end of the QRS complex. It indicates a significant delay in ventricular depolarization, usually in the RV free wall. It does remain a major criterion because when it's clearly present, it's highly specific for advanced ARVC pathology.
Yeah.
It points to significant starring. However, you raised a crucial point earlier. Why does a marker that can be hard to see reliably with significant inter-observer variability retain major status?
Exactly my thought. If clinicians disagree on whether it's even there, and it often only shows up late in the disease anyway, is it still a really useful diagnostic tool for catching the disease early?
That's the clinical dilemma, isn't it? It stays as a major criterion because when you do clearly see it, it's almost pathognomonic, meaning it pretty much confirms advanced disease with scar tissue. But for day-to-day contemporary diagnosis, especially screening, clinicians often rely more heavily on quantitative, more objective measures. For instance, the terminal activation delay, or TAD. TAD is measured on the ECG from the lowest point of the S wave to the very end of all depolarization signals in leads V1, V2, or V3. A TAD duration of CAT's 505 milliseconds in those leads, again in the absence of CRBBB, is a quantifiable sign of depolarization abnormality and counts as a minor criterion. This objective measurement is often more reproducible and potentially more useful in screening earlier cases than trying to spot a very faint, low-amplitude epsilon wave.
Okay, that makes sense. Now, let's talk about the arrhythmias themselves. Can they be used as diagnostic markers?
Oh, absolutely. Arrhythmias are powerful evidence. A sustained ventricular tachycardia, VT, that's VT lasting more than 30 seconds or causing symptoms that originates in the RV, typically presents on the ECG with a left bundle branch block, LBBB configuration. This means the QRS complex looks wide and negative in V1. Now, if that LBBB morphology VT also has a superior axis, meaning the main electrical force points upwards on the ECG limb leads, that specific combination is considered a major criterion. It's highly suggestive of an RV origin, often the outflow tract. However, if you have a sustained or even non-sustained VT, shorter bursts, that still has an LVBB shape but presents with an inferior axis or an unknown axis, or maybe originates from the LV, that gets downgraded to a minor criterion. And even if the patient hasn't had a formal VT captured, high electrical instability still counts. A PVC burden that's premature ventricular complexes of more than 500 PVCs in a 24-hour period on a Holter monitor is considered a minor criterion. This captures that underlying functional chaos, likely driven by the calcium dysregulation we discussed earlier, even before sustained arrhythmias develop.
So the electrical findings definitely point the way, but because ARVC is fundamentally a structural disease, we really need the imaging to provide the physical proof, the evidence of that fibrofatty replacement. Right. Imaging, particularly cardiac magnetic resonance, CMR, and also echocardiography, provides those objective quantitative cutoffs for structural and functional changes that the TFC heavily relies upon.
Yes, the TFC working group set these quantitative cutoffs very carefully, often indexing the measurements to body surface area, BSA, to account for differences in patient size. We're primarily looking for changes in RV size, overall RV function, and crucially, regional movement abnormalities. So a major criterion for size and function, usually derived from CMR, which is better at visualizing the RV, includes severe RV dilatation or severely reduced function. For example, a right ventricular ejection fraction, RVEF, calculated at LEC 40%, is a major criterion. Similarly, gross dilatation, for instance, an RV end diastolic volume index to BSA of continued 2 mm 2 adeles in males, or 100 altirodues in females also counts as a major criterion. These are signs of significant RV damage.
Okay, those are the major cutoffs, big changes. Where do the minor criteria for structure and function fall?
The minor criteria basically cover the intermediate range of structural functional loss. For example, in RVEF that's reduced, but not severely, say, between 40% and 44%, that qualifies as a minor functional criterion. Similarly, RV dilatation that's present, but just below that major threshold, maybe an RV volume BSA between $100.99 up LM to $2 in males, falls into the minor category for structure. These specific numbers are really critical because they help standardize the diagnosis across different hospitals and imaging centers. Now, beyond just the overall size and squeeze, ejection fraction, both CMR and echo are excellent at capturing the real hallmark of ARVC, regional wall motion abnormalities. The presence of akinesia, that's a complete loss of movement in a segment, or dyskinesia, abnormal paradoxical bulging outward movement during contraction, or especially an aneurysm, a distinct localized outpouching of the RV wall, often thin and scarred, finding any of these regional abnormalities is a major criterion. These findings, particularly the aneurysm, visually confirm that localized mechanical failure of the heart wall, likely due to the underlying desmosomal problems.
The source material also mentioned the possibility of using CT angiography or even older techniques like RV angiography to confirm these regional abnormalities. How relevant are those now?
Well, RV angiography, injecting contrast directly into the RV, is certainly not routine anymore. CMR gives us far more detailed anatomical and functional information non-invasively. But historically, its findings of regional akinesia or dyskinesia do still count as a major TFC criterion. CT angiography is becoming more useful, especially with newer scanners. It can show RV thinning, dilatation, and importantly, fat infiltration within the RV wall. However, and this is crucial, interpreting fat on CT requires a high level of expertise. You have to be able to differentiate the pathological fibrofatty replacement seen in ARVC from the normal physiological fat that's often found in the RV wall, especially near the coronary grooves or in the epicardium. It's not always straightforward.
Okay, so we've covered ECG and imaging. Now we move to the final two domains of the TFC. Histopathology, looking at the tissue itself, and genetics family history. Right. Endomyocardial biopsy, EMB, actually taking a tiny piece of the heart muscle seems like it should be the ultimate gold standard for proving there's fibrofatty replacement, but it sounds pretty invasive.
It is invasive, and honestly, its role in routine diagnosis has been significantly reduced, mostly because CMR has become so good at detecting structural changes non-invasively. But it does remain an important major criterion within the TFC framework. The specific major criterion requires quantitative morphometric analysis of the biopsy sample, showing that the amount of residual healthy myocytes is less than 60% of the tissue area, coupled with clear evidence of fibrous replacement, scarring in the remaining tissue. Sometimes fatty tissue is seen too. The big limitation, though, is sampling error. ARVC is often a patchy disease, especially early on. The biopsy needle takes a tiny sample, maybe just a few millimeters across, so there's a real risk of a false negative if the biopsy just happens to miss the diseased area. This limitation is another key reason why comprehensive imaging is now generally preferred over routine biopsy.
Okay, and finally, we arrive at genetics. We've already established that the disease is fundamentally rooted in genetics, often inherited. But interestingly, the identification of a known pathogenic gene variant is only listed as a minor family history criterion in the TFC. That seems incredibly counterintuitive. Why the downgrade?
This is perhaps the most nuanced and, frankly, clinically challenging aspect of the ARVC diagnosis, and it really demands careful explanation. Genetic testing is recommended, especially for cascade testing in family members once a definite case is diagnosed. But finding a gene variant alone is absolutely not enough for a definitive diagnosis of ARVC disease itself.
But why not? If you find a variant in, say, PKP2, and we know PKP2 variants cause ARVC, shouldn't that be enough?
It seems logical, but the reason comes down to two critical concepts: incomplete penetrance and general population prevalence. We now know from large genetic databases that up to maybe 0.5%, that's 1 in 200 people in the general, apparently healthy population might carry a variant in an ARVC-associated gene that's classified as pathogenic or likely pathogenic. Now, if we made finding such a variant a major criterion for diagnosis, we would instantly diagnose potentially hundreds of thousands, maybe millions of people worldwide with ARVC, many of whom might never actually develop the clinical signs or symptoms of the disease. That's incomplete penetrance. Having the gene doesn't guarantee you get the disease. Therefore, the TFC framework rightly insists that the clinical phenotype, the actual evidence of structural changes on imaging or electrical abnormalities on the ECG, must weigh more heavily in the initial diagnosis than the genotype alone. A clinician's primary challenge often arises when counseling an asymptomatic person maybe a relative of a known ARVC patient who undergoes genetic testing and is found to carry, say, a pathogenic PKP2 variant. You're telling a seemingly healthy individual they carry a gene strongly linked to sudden death. But if their ECG and imaging are currently normal, they might only meet that one minor criterion. This absolutely necessitates close, long-term surveillance, but the decision to intervene, perhaps with an ICD, remains entirely dependent on the phenotype actually developing on structural or electrical changes crossing those TFC thresholds. The TFC forces us to observe the disease as it manifests in the individual, not just as it's encoded in their DNA.
That distinction between carrying the gene, genotype positive, and actually having the manifest disease, phenotype positive, is such a critical concept for our listeners to grasp, especially with increasing direct-to-consumer genetic testing.
Absolutely. The goal for these asymptomatic gene carriers is close monitoring, usually starting with baseline ECG, Holter monitoring, echo, and maybe CMR, sometimes beginning in childhood or adolescence, depending on the family history, to catch the very first moment when electrical instability or subtle structural changes begin to emerge and cross that diagnostic threshold.
Okay, the need for this really high level of diagnostic rigor using all these criteria becomes incredibly acute when we start considering how many other conditions can actually mimic ARVC, right? Especially conditions that involve cardiac remodeling or scarring.
The differential diagnosis is indeed extensive, and getting it wrong can be catastrophic. Misdiagnosing ARVC as something benign could leave a high-risk person unprotected, while misdiagnosing a benign condition as ARVC could lead to unnecessary anxiety, restrictions, and even potentially harmful interventions like an ICD. We absolutely must be able to differentiate ARVC from common mimics like athlete's heart, from inflammatory conditions like myocarditis, and infiltrative diseases like cardiac sarcoidosis.
Let's start with the big one. Athlete's heart. This sounds notoriously difficult, especially since we know high-intensity exercise is a potent accelerator of ARVC. Where exactly is the line drawn between normal physiological remodeling in a highly trained athlete and pathological ARVC?
This is a constant clinical headache, particularly in sports cardiology. Athletes, especially those involved in endurance sports like cycling or long-distance running, very often exhibit some degree of RV dilatation just from the high cardiac output demands. This might even satisfy a minor TFC structural criterion on imaging if you just look at the numbers. However, the differentiation hinges on the quality of the RV function and, crucially, the absence or presence of scar. In a typical athlete's heart, while the RV volume might be increased, the overall function, the ejection fraction, and importantly measures of myocardial deformation like RV strain, is typically preserved or even supernormal. The heart is bigger, but it works perfectly, maybe even better than normal. ARVC patients, contrastingly, even those with relatively early disease, usually show abnormalities in RV strain. Strain imaging is highly sensitive to that initial failure of the desmosomal connections and the resulting subtle dysfunction, even before the ejection fraction drops significantly.
Got it. So an athlete's RV might be bigger, but it moves perfectly smoothly. Whereas the ARVC patient's RV might be bigger and often shows regional sluggishness or poor movement picked up by strain.
That's a good way to summarize it, yes. Furthermore, athletes generally lack those distinct regional wall motion abnormalities like dyskinesia or especially aneurysms. Those are red flags for pathology. And they generally show much less propensity for cardiac scarring, which we detect as late gadolinium enhancement, or LGE, on CMR. In ARVC, when LGE is present, it often has a characteristic subepicardial outer layer or mid-myocardial middle layer distribution in the RV free wall, reflecting where that fibrofatty replacement process tends to start. Athletes typically don't show that pattern.
Okay, moving to other structural mimics, how do we distinguish ARVC from cardiac sarcoidosis? That also causes scarring and arrhythmias.
Right, sarcoidosis is an inflammatory condition that can cause granulomatous collections of inflammatory cells to form in the heart muscle, leading to widespread scarring and acting as a major cause of ventricular arrhythmias and heart block. But there are usually distinct clues that point away from ARVC. Sarcoidosis often presents with significant atrioventricular conduction disease like high-degree heart block requiring a pacemaker, which is relatively rare in classic ARVC. Sarcoidosis patients typically lack the clear family history of sudden death or cardiomyopathy that often defines ARVC pedigrees. And they frequently have evidence of sarcoidosis elsewhere in the body, especially pulmonary involvement like enlarged lymph nodes in the chest, mediastinal lymphadenopathy, which we can see on chest X-ray or CT. Imaging is also key here. Sarcoidosis scarring on CMR tends to have a predilection for involving the basal interventricular septum, the thick wall between the ventricles near the valves. That location is often relatively spared in classic RV-dominant ARVC,
which favors the RV free wall. So the pattern and location of scar help separate them.
And what about myocarditis, inflammation of the heart muscle?
Myocarditis is typically an acute inflammation, often triggered by a viral infection. It can certainly present acutely with chest pain, arrhythmias, and ST segment changes on the ECG that might look alarming. Clues pointing towards myocarditis rather than ARVC would include a preceding viral illness, flu-like symptoms, maybe acute ST segment elevation on the ECG, ARVC usually causes T-wave inversion, or specific CMR findings indicative of acute inflammation, such as myocardial edema, swelling, or sometimes pericardial involvement, inflammation of the sac around the heart. While the scarring left behind after myocarditis resolves myocarditis, can sometimes mimic the LGE pattern seen in ARVC, the overall clinical context, the acute presentation, the lack of a strong family history, the potential viral trigger, usually points away from a chronic inherited condition like ARVC. Now, while we focused heavily on the classic RV-dominant picture because of the name, it's really vital we circle back to that modern consensus. ARVC is often, maybe even usually, a biventricular disease. The term arrhythmogenic cardiomyopathy is increasingly warranted because only a minority of genetically confirmed cases seem to be purely isolated to just the right ventricle. The LV gets involved too.
So what are the key indicators we should look for that suggest there's significant left ventricular or LV involvement happening alongside or even instead of the RV issues?
LV involvement is primarily defined by findings like LV dilatation, the chamber getting bigger, reduced LV systolic function, a lower LVEF, and importantly, the presence of scarring, or LGE, within the LV wall itself on CMR. This LV dominant or biventricular phenotype is particularly associated with certain genetic variants, most notably mutations in DSP, the gene for desmoplasmin, and PLN, the gene for phospholamban.
Does the LV involvement tend to present differently on the ECG or imaging depending on which gene is involved? Can we see gene-specific patterns?
Yes, increasingly we think the genetics can influence the presentation quite strongly. Patients with significant LV involvement often show T-wave inversion that extends beyond the usual right precordial leads, V1 to V3, and affects the lateral leads like V5, V6, I, AVL, and sometimes the inferior leads, 2, 3, AVF as well. That widespread TWI suggests more global involvement. When it comes to imaging, particularly with LGE on CMR, patients with DSP variants seem to display a highly characteristic pattern. It's often a subepicardial, just under the outer surface, or mid-myocardial LGE, frequently in the lateral or inferior walls of the LV. Because this scar pattern can be patchy and often spares the endocardium and inner lining, it can sometimes be mistaken for the scarring seen after myocarditis, which is why clinical context and genetics are so important. Meanwhile, the PLN variants, specifically the R14-MEDL mutation common in the Netherlands, is known to be highly variable.
It can manifest as classic ARVC features, but perhaps more commonly it presents as a phenotype that looks very much like dilated cardiomyopathy, DCM, with significant LV dilation and dysfunction, sometimes with less prominent RV involvement initially. This is exactly why genotyping is becoming so valuable. It helps clinicians anticipate the likely pattern of disease expression and progression.
And what's the bottom line, the clinical implication of having LV involvement? Does it change the outlook?
Oh, absolutely. It dramatically increases the risk. Multiple studies have shown that having a left-dominant or clearly biventricular phenotype carries a significantly higher risk, roughly a 3.4-fold increased relative risk for suffering serious ventricular arrhythmias compared to patients with disease apparently isolated just to the RV. Identifying LV involvement is a critical risk modifier when deciding on management, especially concerning ICD implantation. It tells you the disease is more extensive and likely more aggressive.
Okay, so everything we've covered so far, the genetics, the pathophysiology, the diagnosis, the differential, the patterns of involvement, it all leads to this final and arguably most urgent clinical requirement: accurately identifying which patients are at the highest risk of experiencing a serious arrhythmic event, or SAE. And just to clarify, SAEs encompass the worst outcomes: sudden cardiac death, SCD itself, resuscitated cardiac arrest, meaning they survived an SCD event, and sustained hemodynamically unstable ventricular arrhythmias, like VT causing fainting or near fainting. So how do we pinpoint the patients most likely to suffer one of these?
Well, the absolute strongest predictor, which automatically puts someone in the highest risk category and mandates intervention, usually an ICD, is a history of one of those prior events. So if someone has already survived a cardiac arrest or had documented sustained ventricular tachycardia causing symptoms, that's a Class 1 indication for secondary prevention. For primary prevention, trying to predict the first event in someone who hasn't had one yet, we rely on combining multiple factors: clinical, electrophysiological, and imaging predictors. Starting with the clinical factors. Male sex consistently emerges as an independent predictor of higher risk. Males seem to have somewhere between a 1.6 to 3.2-fold increased relative risk of SAEs compared to females with ARVC. This higher risk is thought to be multifactorial. Partly, it might be attributed to a potentially higher lifetime dose of strenuous exercise often seen in males, who we know accelerates the disease. And partly, there might be a direct influence of sex hormones, with some evidence suggesting testosterone could potentially exacerbate the phenotype, although that's still being researched.
Interesting. And how does age factor into this risk curve? Is it worse the older you get?
Actually, it's a bit counterintuitive. The risk is tightly linked to age, but it's not simply linear. The risk of sudden death seems to be lowest before puberty, say before age 16. It then peaks significantly during late adolescence and early adulthood, think late teens to early 30s. After that, the risk appears to gradually decline again in later life. Therefore, being diagnosed at a younger age, specifically late till 30 years old, is considered a strong independent predictor of future events. This likely reflects that peak vulnerability period where the underlying disease substrate has progressed enough to cause events, but the patient is still young and often physically active.
And syncope fainting, sometimes that gets dismissed as just fainting, but here it sounds like it acts as a massive red flag.
Absolutely. A history of unexplained syncope, meaning a transient loss of consciousness that isn't clearly due to something simple like dehydration or standing up too fast, is consistently associated with about a 2 to 3-fold increased relative risk of subsequent SAEs in ARVC patients. Syncope in the context of diagnosed or suspected ARVC should really be treated with extreme caution, potentially as equivalent to an aborted sudden cardiac death event, until a clear non-arrhythmic cause is found. It's a major warning sign.
Okay, let's look at the electrical predictors now. We already know T-wave inversion is important for diagnosis, but how does it predict risk? Does more TWI mean more risk?
Yes. The extent of T-wave inversion on the 12-lead ECG is definitely key for risk stratification. If the TWI extends beyond the typical V1, V3 pattern, say into V4, V5, or V6, or if it also involves the inferior leads 2, 3 AVF or lateral leads I, AVL, suggesting more widespread disease or potential LV involvement, that becomes an independent predictor of higher SAE risk. Essentially, more extensive TWI visually maps onto a larger, more complex arrhythmogenic substrate within the ventricles, making dangerous reentrant circuits more likely. We also look for other signs of electrical scarring and instability on the ECG. Markers of depolarization abnormalities, like having a fragmented QRS complex where the QRS has extra notches or slurs, or the presence of light potentials on a signal-averaged ECG, SAECG. These all indicate larger areas of slow conduction due to scar and fibrosis, and they correlate with increased risk.
And the PVC burden, the threshold for high risk, is even higher than the one for diagnosis, right?
That's correct. While having more than 500 PVCs in 24 hours is a minor diagnostic criterion, a higher burden, specifically $1,000 PVCs per 24 hours, is considered a strong predictor of future SAEs. This reflects a higher degree of underlying electrical instability and strongly correlates with the risk of initiating sustained VT or VF. Similarly, if ventricular arrhythmias, VTVF, are easily inducible during programmed ventricular stimulation testing in the electrophysiology lab, that also suggests a higher risk substrate, although the predictive value of EP testing is still debated in ARVC.
Okay, and finally, the imaging data, the structure and function itself, how does that feed into risk?
Gross functional impairment is always a significant predictor of poor outcomes in most heart diseases, and ARVC is no exception. An RVEF, right ventricular ejection fraction, or LVEF, left ventricular ejection fraction, that is moderately or severely reduced, generally defined as LA 50%, is associated with roughly a 3 to 4-fold increased relative risk of SAEs. And again, we have to emphasize that evidence of LV involvement is particularly concerning for risk. Even subtle LV functional changes, perhaps detected only by advanced techniques like strain imaging before the LVEF drops significantly, indicate a higher risk profile, reinforcing why identifying that left-dominant or biventricular phenotype is so critically important for risk stratification. So the culmination of understanding all these individual risk factors led to the development of a really useful quantitative risk stratification tool, moving beyond just listing factors.
Right. We had the 2015 International Task Force Consensus Recommendations, which use categories like major and minor risk factors. But I understand those sometimes struggled with patients who fell into an intermediate risk zone. This led to the creation of the newer quantitative risk calculator, correct?
That's exactly right. The field recognized the need for a more granular, patient-specific estimate of absolute risk, rather than just categorizing people. This led to a large multinational collaboration involving data from 15 experienced ARVC centers worldwide.
They developed and validated the ARVC risk calculator, which you can actually find online at rvcrisk.com. This tool integrates several of the most powerful predictors we just discussed: the patient's age at assessment, their sex, any history of unexplained syncope, the extent of T-wave inversion on their ECG, their 24-hour PVC count, whether they've had non-sustained VT, and their RVEF. This calculator is critical because it moves us away from a somewhat subjective weighing of risk factors towards generating a specific, calculated 5-year risk probability of experiencing sustained ventricular arrhythmia or sudden death.
That sounds incredibly useful. So how do clinicians then translate that percentage risk into the very real-world, life-altering decision about whether or not to implant an implantable cardioverter defibrillator, ICD?
Yeah, the decision-making process has become more standardized around these calculated risk cutoffs, although clinical judgment and patient preference always play a crucial role, especially in those intermediate cases. The generally suggested thresholds are: if the calculated 5-year risk is high, let's say greater than 15%, then an ICD is usually strongly considered or recommended. If the patient falls into that intermediate risk range, maybe between 5% and 15% 5-year risk, then an ICD may be considered. This is where discussion is key. Factors not fully captured by the score might sway the decision, things like the specific gene mutation if known, participation in competitive sports, strong family history of very early SCD, or the patient's own tolerance for risk versus device complications. For instance, a 12% risk patient who insists on continuing high-intensity sport might be viewed differently than a 6% risk patient who strictly adheres to exercise limits. And if the calculated risk is low, say less than 5% over 5 years, then an ICD is generally avoided, as the potential risks and complications of the device likely outweigh the potential benefit in that scenario.
That quantitative approach seems vital because, as you alluded to, the decision to implant an ICD is definitely not taken lightly. The device itself, while life-saving, carries its own significant baggage, including annual complication rates.
It certainly does. While ICDs absolutely save lives, and again, they are mandatory for secondary prevention after a cardiac arrest, they also impose a considerable burden on patients. The source review quotes an annual rate of inappropriate shocks, where the device shocks for a rhythm that wasn't life-threatening, like SVT or noise, of around 3.9%. And other complications like lead malfunction, breaking or dislodging, or device infection occur at a rate of about 4.2% per year. So over the lifetime of the device, the cumulative risk of complications is substantial. We are always balancing that absolute risk of sudden death without the device against the near certainty of experiencing some device-related complications over time.
Okay, so once the risk has been carefully stratified and the decision about an ICD made, we move to the ongoing management strategies, starting with the most basic, yet perhaps the most difficult intervention for many patients: exercise restriction. We've clearly established that strenuous exercise acts like fuel on the fire in ARVC, accelerating the phenotype, likely because of that calcium dysregulation under high ventricular stress. So what is the practical evidence-based recommendation? How much restriction is needed?
Yeah, exercise restriction is considered absolutely crucial. It's a cornerstone of management for every patient diagnosed with definite ARVC, for those considered borderline, and importantly, even for those individuals who are genotype positive, but still phenotype negative, the asymptomatic gene carriers. The recommendation, based on observational data, is quite rigorous. Restrict exertional activity to less than 650 MET hours per year. Now, to put that into context for you, 650 MET hours per year is roughly equivalent to limiting structured physical activity to about 30 minutes of brisk walking per day, maybe 5 days a week, above their baseline normal daily activities. This specific benchmark comes from studies showing that ARVC patients who consistently exercised above this threshold had significantly faster disease progression, more structural change on imaging, and a higher rate of arrhythmic events over time.
Wow. That must be an incredibly difficult conversation to have, especially with someone who is young, maybe a competitive athlete whose identity might be deeply tied to their sport. You're essentially asking them to fundamentally change their life, potentially their career, to save their life.
It is arguably the hardest part of managing ARVC for many patients and their families. It requires a really delicate balance between clearly communicating the serious physical risks of high-intensity exercise and trying to preserve the patient's mental and overall physical health, which also benefits from some activity. But the core message has to be unambiguous. Endurance sports, high-intensity interval training, competitive sports involving bursts of intense activity, these are unequivocally contraindicated. The mechanism is strongly suggested, if not definitively proven. Repetitive mechanical strain combined with high adrenergic tone appears to directly damage the fragile desmosomal connections and promotes the fibrosis and fatty replacement process.
Okay, moving on to pharmacologic therapy. Is there any medication currently available that can fundamentally slow down or reverse that fibrofatty replacement process, a disease-modifying drug?
Sadly, no. That's the holy grail we're searching for, but currently there is no proven disease-modifying pharmacotherapy for ARVC. All current medication management is focused purely on controlling the arrhythmias, not halting the underlying structural progression. The first-line drug class, despite a lack of large randomized controlled trials specifically in ARVC, is the beta blocker. Beta blockers like metoprolol, bisoprolol, atenolol are strongly recommended for any patient who experiences non-sustained VT or has a significant burden of PVCs. The rationale is straightforward. We know adrenergic drive triggers the TEX2 plus needed arrhythmias, so beta blockers, by dampening that sympathetic tone, should theoretically reduce the triggers for those arrhythmias. Other antiarrhythmic drugs might be used if beta blockers alone aren't sufficient. Sotalol is often a good choice, as it has both beta-blocking effects and class 3 antiarrhythmic properties affecting potassium channels. Drugs like flecainide, a sodium channel blocker, or amiodarone, which affects multiple channels, are typically reserved for patients with very frequent or refractory VAs causing symptoms or ICD shocks. However, the critical caveat always remains. Even if antiarrhythmic drug therapy is successful at reducing the burden of arrhythmias, fewer PVCs, less non-sustained VT, it does not provide sufficient protection against sudden cardiac death to negate the need for an ICD in patients who meet the high-risk criteria. Drugs suppress arrhythmias, ICDs terminate potentially lethal ones.
Right. Let's focus then on the implantable cardioverter defibrillators, the ICDs. We know secondary prevention after an event is a class 1 indication. For primary prevention, what are the clearer indications that might push someone towards an ICD even outside of just the risk score calculation?
For primary prevention, beyond the risk score, ICD implantation is generally advised for patients who have a documented history of sustained VT, even if it didn't cause cardiac arrest. Just sustained VT itself, lasting 30 seconds or causing symptoms, indicates a very high-risk substrate. It's also strongly recommended for patients who present with severe RV or LV dysfunction at diagnosis, typically defined as an RVEF or LVEF of 3 up 45-40%. That level of pump failure itself carries a high mortality risk, including arrhythmic death. The risk calculator really serves best to guide the decision-making for those patients who fall between these clear-cut indications, those with maybe mild or moderate RV dysfunction, non-sustained VT, and other risk factors where the absolute risk is less certain.
Is there any unique challenge that the underlying pathology of ARVC poses specifically to the function or longevity of the ICD device itself?
Yes, there is potentially a technical challenge linked directly to the disease process. As the right ventricular myocardium, particularly near the apex where ICD leads are often placed, is progressively replaced by non-conductive fat and fibrous tissue over years. The amount of healthy muscle available for the ICD lead's tip, the electrode, to reliably sense the heart's intrinsic electrical signal, the R wave, can decrease. This gradual loss of viable myocardium under the lead tip can potentially lead to reduced R wave sensing amplitude over time. If the R wave signal becomes too small for the device to reliably detect, it might fail to recognize a true VTVF event, or might oversense background noise, increasing the risk of inappropriate shocks. This can sometimes necessitate lead revision surgery years down the line, more so perhaps than in other conditions.
Okay, so let's say a patient has an ICD. They're on the best possible drug therapy, but they're still experiencing breakthrough VAs, maybe getting shocks. What's the next step in management?
In that situation, the next step is usually catheter ablation. Ablation involves using catheters inserted through the veins, or sometimes arteries, to map the heart's electrical activity, identify the abnormal tissue or circuits causing the VT, and then deliver energy, usually radiofrequency heat or cryocold, to destroy that problematic arrhythmogenic substrate. Ablation in ARVC is typically reserved for patients with recurrent drug-refractory VAs, especially if they are causing frequent ICD shocks, which significantly impacts quality of life. Now, ablation in ARVC is known to be particularly complex, more so than for many other types of VT. Why? Because electroanatomical mapping studies where they create detailed 3D voltage maps of the heart chambers have consistently shown that the primary substrate, the low-voltage scar tissue that generates and sustains the VT circuits, is predominantly located in the epicardium. That means on the outside surface of the right ventricle, rather than the endocardium, the inside lining.
Ah, okay, so if the main problem, the scar tissue causing the short circuits, is mostly on the outside of the heart wall, then the standard endocardial ablation approach, where the catheters are manipulated inside the heart chamber, might not effectively reach the source of the VT.
Exactly. The disease process in ARVC often seems to start epicardially and progress inwards. So mapping only from the inside, endocardially, will often underestimate the true extent of the scar and might miss the critical isthmus of the VT circuit. Therefore, most experienced ARVC ablation centers now routinely perform or are prepared to perform a combined endocardial and epicardial approach. This involves safely accessing the pericardial space, the sac surrounding the heart, using a needle puncture under the sternum, allowing catheters to map and ablate directly on the external surface of the RV where the substrate is often worst. While ablation, especially with combined endo-epi access, can significantly reduce the burden of VAs and ICD shocks for many patients, it's important to remember it's generally not considered a cure. It's an important adjunct therapy to reduce shocks and improve symptoms, but it typically doesn't eliminate the need for the ICD backup in these high-risk patients.
That makes sense. Finally, under what circumstances would cardiac transplantation become the necessary option?
Transplantation remains the ultimate treatment option for end-stage ARVC, when other therapies have failed or are no longer sufficient. The predominant indication is usually advanced RV dysfunction, or sometimes biventricular dysfunction that progresses to severe symptomatic heart failure refractory to medical management. It can also be indicated, though less commonly, for patients who suffer from truly intractable, hemodynamically unstable VAs, sometimes called electrical storm, that are refractory to multiple attempts at catheter ablation and maximal antiarrhythmic drug therapy, when the arrhythmia burden just cannot be controlled. Fortunately, the long-term prognosis for ARVC patients who undergo cardiac transplantation is relatively favorable, often better than for patients transplanted for more common conditions like ischemic cardiomyopathy, provided they can get through the surgery and initial post-op period. #tag future directions and takeaway. Looking ahead now, the future of managing ARVC really lies in moving beyond a sort of one-size-fits-all approach and truly leveraging the increasingly detailed genetic differentiation we're achieving.
How specifically do you see genotyping changing therapy in the near future? Will we treat a PKP2 patient differently from a DSP patient?
I think inevitably yes. We can already start to anticipate the likely disease trajectory based on the specific gene involved. For example, as we discussed, PKP2 variants tend to cause the classic RV-dominant phenotype, perhaps with a slightly slower progression in some cases. However, DSP variants are increasingly recognized as being associated with a potentially more aggressive clinical course, often with earlier and more profound LV involvement, and maybe a higher burden of progressing to heart failure needing transplantation. And then some data suggest DSG2 variants might be more frequently associated with severe biventricular dysfunction and perhaps a faster progression towards needing transplantation compared to PKP2. So future clinical guidelines will almost certainly start to customize recommendations for surveillance intervals, the frequency and type of imaging, perhaps even the thresholds for ICD implantation or the choice of antiarrhythmic drugs based on these specific genotype-phenotype correlations.
We also touched earlier on the possibility of identifying the disease even before significant structural damage is visible on standard imaging. How close are we to that?
That's a huge area of research. Early detection is paramount if we ever hope to intervene before irreversible damage occurs. Since we believe functional failure, like problems with contraction or relaxation, precedes the gross structural remodeling, the fattened scar, advanced imaging techniques that focus on subtle changes in myocardial function are gaining a lot of traction, specifically measuring RV strain using techniques like speckle tracking echocardiography or other sensitive measures of RV mechanical deformation. These tools might allow us to identify subclinical ARVC maybe in those asymptomatic gene carriers who haven't yet met the formal TFC criteria for gross structural abnormality like dilatation or wall motion problems. If we can reliably catch that very early functional failure, it might open a window for earlier or more aggressive therapeutic intervention, maybe much stricter exercise restriction from day one, or perhaps earlier initiation of beta blockade or other potential therapies before the irreversible fibrofatty replacement really takes hold. That's the hope.
And finally, you mentioned some very promising research looking into autoantibodies. Could ARVC have an autoimmune component?
This is a really fascinating and potentially paradigm-shifting avenue. Several research groups have now found evidence of autoantibodies. That's the immune system mistakenly attacking the body's own tissues, directed specifically against sesamosomal proteins like DSG2 in a significant proportion of ARVC patients. If this finding is robustly validated and we understand its role better, it opens up at least two exciting possibilities. First, it could lead to a potential new diagnostic blood test. Maybe measuring these anti-desmosomal antibody levels could help distinguish ARVC from its mimics like myocarditis or sarcoidosis, or even track disease activity. And second, perhaps even more excitingly, if there truly is an inflammatory or autoimmune component driving or exacerbating the disease progression in at least some patients, it raises the possibility of developing novel immunomodulatory treatments, therapies aimed at dampening down this harmful immune response as a future way to treat ARVC. That would be a major breakthrough.
Okay, so to try and synthesize this really intensive deep dive for you, our listener, arrhythmogenic right ventricular cardiomyopathy, despite its name often focusing on the RV, is really a highly heterogeneous clinical disease. But it seems to originate from a single fundamental mechanism, that catastrophic, often inherited failure of the intercalated disc, particularly the desmosome complex. This failure leads to both electrical chaos, driven early on by calcium mishandling, and progressive structural replacement of heart muscle with scar and fat.
And the current state-of-the-art approach to diagnosing and managing it absolutely demands diligent quantitative integration of multiple lines of evidence. You need the clinical history, you need careful analysis of complex electrophysiological markers like TAD and the extent of TWI, and you need quantitative imaging parameters, especially from CMR. All of this data needs to be synthesized, ideally using objective tools like the ARVC risk score, to accurately assess the individual patient's risk of sudden death and guide those critical management decisions, especially regarding exercise and ICDs.
Right. And given that we've established just how powerful and independent a risk marker strenuous exercise is, how it clearly accelerates both the phenotypic expression and the disease progression, let me leave you, our listener, with maybe a provocative thought to consider. Our current risk scores are excellent quantitative tools. They're built on observing large amounts of patient data over time. But if a patient who is deemed high risk, perhaps partly because of a history of intensive athletic activity, then strictly adheres to the mandated exercise moderation, that 650 met hour per year restriction, how quickly and to what extent does that critical behavioral change actually alter their predicted long-term risk, which was derived from those very scores based on past behavior? It really gets to the core question of whether we can truly halt or maybe even partially reverse the molecular damage and the downstream risk once the disease process has already begun, simply by removing one of its major accelerators. It's something the field is still actively trying to understand. Thank you for watching The Funnel Effect.